Thank you so much. And I don't know who didn't feel like dancing, but that was an amazing video. Welcome to everybody, and what a thrill and pleasure it is for me and all the panelists to join you here to talk about impact. We've had such a fantastic conversation over the last 2 days, and really what's fantastic is that we've been waiting for the last 3 years to talk about impact, and that the upcoming AI Summit is about impact, is what is bringing a lot of conversions across global north, global majority, development organizations, private sector, different countries, because we know that the world around us is shifting, but it is also creating some really unique opportunities. And we are here to talk today about some of the opportunities that are coming from the ground, from across many geographies. And I am thrilled that the star of today's panel are these amazing innovators from across the world. On stage, we have Tiago from Brazil. Tiago, please put your hand up. Tiago, he's been solving this teacher-student ratio to help improve student writing and literacy. And he's been on a fascinating journey across as an investor and an entrepreneur, leveraging networks for exponential change. And just in the last panel, we heard about what may we do to institutionalize some of the networks where the impact that are emerging can be exponential and global in nature. We also have Benjamin from Jacaranda Health, and he's been bringing AI to serve the needs of mothers at scale in health. We also have Almedi from Deep Leaf from Morocco, operating in a number of countries and helping farmers increase yield and reduce pesticides. And then we have Kidis from Zene Health in Ethiopia and Rwanda, looking at the supply chain solutions for healthcare providers to reach the remotest communities. And as you can see, this panel is about people. We'll certainly talk about AI, but it is about AI plus people. And it is about how that thrilling combination creates that safe impact at scale. Now, all of them are on stage because they've moved beyond the pilot stage. Zene Health, 50,000 women and growing. Jacaranda Health, serving 1.8 million mothers. And Benjamin, you're going to correct that number shortly, if it's more than that. Deep Leaf across 1 million hectares across a number of countries. And Tiago, you'll have to tell us what your number is. So I'm going to turn to you, and across my panel members, if you can just give us a sense of what has been your journey from 0 to 1 to exponential scale. How hard has that journey been? Where are the users in that journey? But also, can you talk about where is AI in that journey? Tiago, over to you.
Thank you. It's a pleasure to be here. I'm honored. So telling a little bit about our journey, it's important to give some context. In Brazil, just 1 out of 10 adults can be considered fully literate, can read a high school book or write a 1-page dissertation. So it's a huge, huge problem. And when we try to understand where the problem is, obviously it's inside the school. And what we notice very clearly is that students, they don't have the chance to write regularly. And we know that the only way for you to learn how to read and to write is to practice, meaningful practice. And they don't have that opportunity. And when they have the chance to write, they don't have feedback. So that's a huge issue. And that's the problem we tried to solve right in the beginning, 10 years ago. So 10 years ago, we look at that problem, and we tried to figure out how to solve it. And we didn't think about AI. We didn't think about technology, to be honest. But when we noticed and understood the problem they were trying to solve, the problem was that teachers were overloaded with work. They didn't have the time, the energy, and the compensation to really focus and spend time doing the assessment, the grading, and the support the students needed. So by then, we understood that technology could play a huge role in that process. So what we did was to develop our own AI back in 2015 that could really understand, comprehend students' writing, and give meaningful feedback right away. So that process of really understanding students' gaps and giving them clarity about what they have to focus allowed them to really improve their writing skills very, very quickly. So we started back then in 2015, 2019. We had the chance to run an RCT funded by JPAL, the lab at MIT, founded by Abhijit Banerjee and Stella Duflo, Nobel Prizes in Economics. And that RCT proved that our program really helped students improve writing skills very fast at scale. So after that RCT in 2019, we started to be demanded by governments in Brazil to run our program as their official writing and literacy program for students' skills development in literacy. So we've been scaling that program since then. We have covered and supported more than 4 million students since then, working as public policy, official public policy in different states and cities around Brazil. And right now, we're looking for an international expansion. We're exploring new markets that could fit our program to their needs. So in a nutshell, that's pretty much what our journey looks like.
Tiago, thank you so much for sharing. Can I probe you a little bit and ask, was there a problem in unlocking data? Did you have issues with access to compute? What about the linguistic and cultural diversity of Brazil?
Mm-hmm. That's a very core question. So back then, we didn't have data. We basically didn't have data. But we had something that was really special. We have a national exam in Brazil for the end of high school. And at the end of high school, they have a writing piece. They have an essay. And that essay is a huge data set. However, it was all manual. And at the time, there was no OCR. So what we did, we hired a lot of masters and doctoral students from the linguistics department of many universities for them to type the essays and start making linguistic notations so we could start identifying the standards, the patterns of those essays. And that was the initial data set we had. And once we had the students write on our platform, we started to make this corpus richer and more relevant. So it always started very small, very manually. And now, obviously, we don't have to do that anymore. But we still need the human piece improving and indicating to our AI what we have to do to be more precise, to be more assertive, and to give a better feedback for our students.
Tiago, thank you so much. We're going to come back to you, and I'm sure the audience has a lot of questions. Almadi, I turn to you. Tell us about your journey from Morocco to Bangladesh to Kenya. What are you doing, and how are you building these use cases for impact?
Thank you very much for having me here. So Deep Leaf journey started 3 years ago when we had the first yields lost due to pests, a pest attack on our tomato greenhouse in my hometown. The pest was Tuta absoluta, which is a flying pest insect that makes mines inside the tomato leaves. So farmers were confused how to treat this pest. Many agro dealers were taking this opportunity to sell their pesticides. So the farmers ended up using excessive pesticides. They had a lot of residues, and they weren't able to sell their produce anymore due to the regulations. Some farmers were exporting. They weren't able to export due to European regulations. So my father was one of those farmers, and that's where I had to come in and create a solution that will help farmers reduce chemicals. So we created a simple deep learning model using ResNet, which is an open source algorithm. We trained it on the images of this pest, and then we've been able to identify the early signs and provide organic treatments and preventive measures instead of chemical pesticides, because at the early stage of the detection of the pest, you're able to use these solutions, these alternatives. And then it worked, and we thought, why not scale it into multiple crops? We found that there were already many startups doing the same, but the AI models were fragmented. Every country develops AI models for disease detection for some crops that they have in their fields. Farmers need to do crop rotation, so they need to install other AI models. So you find a farmer mobile phone filled with different apps, different mobile AI models. Each one is specific for some crops, and each one has a different user experience, and so on. And as you know, smallholder farmers, who are 80% of African farmers, can't actually learn every user experience. They can't even learn one of them. So we had to unite all of these crops under one AI model. We won some competitions where we got access to open data with the FAO. We trained the AI model on 57 crops, and now we are offering one API that allows you to detect 1,000 pests, disease, and nutrition deficiencies under one mobile app. Now we are in front of another challenge, which is affordability, making this affordable and accessible by smallholder farmers. So the solution for it is compute. And thanks to different initiatives, we've been able to access this compute. And now we provide it free for all the smallholders in Africa, currently at 5 million smallholders. And in order to unlock this growth, because farmers, even if it's affordable, you want to be able to reach them via social media or digital marketing means. So we pivoted from a mobile app into an API that integrates with existing platforms. And that's where collaboration comes. We started collaborating with different agri-tech companies from different countries of Africa and Middle East, integrating with their platform, enhancing their value proposition by adding this disease detection feature. And then we started discovering that this AI doesn't only diagnose and provides treatment, but it's fixing a huge food security problem that allows us to have use cases with governments, with banks, insurers, more segments in the market that we never imagined before. The first use case, which is the most important, so I can keep it short, I'll talk about it. It's the food security grants that governments provide to farmers so they can have access to treatment and fertilizer. The first customer was Qatar. There was a Deloitte report showing that 70% of their funding that goes to tenders and grants to get fertilizer go in for the wrong treatments, because the farmer doesn't have expertise or knowledge to discriminate between two different pathogens, because they have the same visual features. So they end up asking for fertilizer that's the wrong active ingredients, that have the wrong active ingredients. So the use case here is very simple. These mobile apps where farmers get access to treatment and fertilizer, instead of letting them manually choose from the list, they have to take a picture first, and then the AI will tell them which treatment they are eligible for. Then they get their voucher and go to the agro dealer to purchase. So that's how the journey been, from a problem that touched my community into a solution that feeds families in Africa, into a use case for food security programs.
Amazing, Almadi. Thank you so much for that illuminating journey. I now want to go to Ethiopia. Kidis.
Yes, thank you. Thank you all for having me and for joining us. So as mentioned, I am from Ethiopia. And maybe I'll give a little context about Ethiopia for those that aren't familiar with it. So in Ethiopia, we're the second largest populous country in Africa. Fast growing population, fertility rates are quite high. And that's kind of where we come in as Yane Health, working on women's health. I know you mentioned we're in the supply chain earlier, but at the core of what we do is actually women's health and women's health commodities. In Ethiopia, when you look at the AI landscape, it's heavily government-driven, it's government-led. Since 2021, Ethiopia as a country has taken a commitment in being the AI hub spot for Africa and for innovation around AI and technology and improvement. So there has been a lot of investment and appetite from our government. However, private sector is still has the strength in terms of innovation is coming from private sector. Use cases are coming from private sector. However, the regulatory landscape is still more favorable to government entities. So I think just with that understanding, it can show you as we're one of the ones that are in the health tech space that are trying to be a pioneer as a private sector actor and also build these use cases that are national priorities. For us at Yane Health, and I've kind of jotted things down, so I want to kind of share the journey in a way that can be useful for our discussion. AI doesn't start with a model. It starts with a young girl in her room on her phone, whispering or typing a question about, I'm pregnant, I don't know where to go, what do I do? How do I tell my parents? I think I may have caught an STD. What do I do? My menstruation hasn't been here for 2 months. Do I have a condition? It really starts with her problem, the stigma she's dealing with, and how do we provide that access for her where she feels safe. So I'm going to, again, focus on kind of the experience around women that actually use our products. We are, just like Thiago as well, we didn't start off as an AI company. In fact, we still aren't an AI company. We're a healthcare provider for women's health. And in our early days, it was really thinking about how do we solve problems around women's reproductive health. Maternal and child health is a big issue for most sub-Saharan African countries, if not all. And same like Ethiopia, there are 27 million women of reproductive age that still today have an unmet need for accessing contraception, for accessing care, and learning about these topics. We're not teaching young girls about menstruation in high schools. We're not teaching girls about sexual health and so on. So by the time they're experiencing their first instance of pregnancy or a condition they have, it's usually the first time where they're going to a facility to get treatment for it, which is too late oftentimes. So that's kind of where we started. And I think the key thing around that is, for us, we have to remember that behind every tool and behind any solution, there is a person dealing with a problem. And that's kind of been the lens in how we started at Yane Health. So today at Yane Health, we are a mobile application that provides multiple features for women. We have an online we have a mobile period and menstrual and pregnancy tracking feature on the app. We have an online educational portal where they can learn about SRH, sexual reproductive health, maternal health topics without stigma in their own language. And then we have an online telehealth service and online pharmacy, so they can access practitioners privately, discreetly, via video chat and audio, and also get prescriptions delivered to their home stigma-free and discreetly. Now within that, we have multiple use cases that we've kind of been piloting and trying in the last couple of years. We relaunched our app officially last year, actually, so we've seen fast, rapid growth in our app and uptake of women. But when we started, day one, we didn't have data. We didn't have an idea of what would be most efficient, and we really honed in on the human-centered design as part of our development with our product. So in the early days, we really gathered a lot of women for focus group discussions. We had online surveys. We gathered women in communities. We went to facilities to kind of talk to women and listen to them. We really listened. What is your problem? What are you experiencing in this? What are the gaps? And those early day discussions have really shaped to the use cases that we're prioritizing today. So again, with Ethiopia being a government-led and healthcare services are provided, over 80% of the market is provided by government in Ethiopia. So private sector doesn't have a stronger market share yet. And a lot of the data sits within government. And because Ethiopia is still at its infancy of AI, data privacy, data sharing policies, it's been difficult for us to get anonymized data from government as well, to build AI models to help with our menstrual tracker or pregnancy early detection and so on. So we've had to really start with the data that we had, and it wasn't much in the early days, right? We were dealing with thousands of data points, not enough, but it still was enough to understand what questions women were asking. We started an online a Telegram chat bot, actually in our first use case with our AI chat, where we just we're seeing how are women asking questions, what time were they asking questions, what languages did they prefer, were they using emojis, were they using different dialects, which really helped us understand the human aspect of it. We even went into different regions to talk to women from different socioeconomic classes and tried to understand, what is their understanding of technology and AI. And interestingly, And one community we went to, women, it was a conservative region and community where they're very religious, and they felt like AI was evil. They really believed that, how can something that doesn't know me tell me what I need? And the fact that they were sharing intimate information about their sexual health, their maternal health, their reproductive health, they felt like it was going against their personal beliefs, religion, but also they were like, can I even trust the system? Is there somebody that actually can validate this? Is there a provider behind this? So we really got a chance to see it from that level of, there has to be a lot of advocacy done around what AI is, especially when you're providing healthcare services that requires trust at the core. And I think that was one of the biggest challenges. First is like, forget about the data and what we can build, but if the users don't feel confident in the system and the tool that they're using, we're not going to reach impact. You know, our AI model or any AI model can be 95, 99% accurate, but if the user doesn't feel trust and feel confident and feel like their information is private when they use it, there's really no impact that we're going to see. So I think that really helped us shape it. And also we went multiple times back to our platform on our app, on our bot to redesign the app. We even in fact had a researcher do a human-centered design study on our UX and UI in terms of how do we engage, you know, what is the tone of our messaging when we're talking to women about these topics. It can't be robotic and feel very static. It has to feel like there's a person behind there that actually cares. We had to change the tone of our messaging. We had to change, put in guardrails that won't say things that would impact or that would influence people based on their religious background or their cultural beliefs. So a lot of these things happened when we brought in the users into that building the product. And today, you know, where we're not at national wide scale of our solution and our different use cases, that we're experimenting with. However, we have a clear path of how we need to build and what areas we have to really focus on as a B2C provider, where the end user really has to understand what they're using, and not really spending a lot of money on, you know, the technicalities of it, but really also focusing on the user experience of these tools. And I'm sure there's more questions we can unpack, but that's pretty much what we do. I guess in terms of use cases, like I said, on our app, we forecast and predict women's menstrual cycles. We also notify them on early danger warning signs for pregnancy challenges. We recommend different contraceptives or services if they're, you know, planning to conceive, or if they are planning to get on a birth control. We help them decide what's the best option for them based on the input that they use. So it's really personalizing their care. And also we're experimenting with triaging patients to our telehealth service. So really telling them who they should be talking to and speaking to quickly, but also in a way that is safe and that they understand. And we're always being responsive as well. So I mean, that's what we're doing today. We don't want to reinvent the wheel. So we always think about collaboration. We work closely with the government as well, leveraging their infrastructure and their resources. But the biggest thing that has got us this far so far as a startup as well has been the financing piece of it. You know, we want to be sustainable. We are a social enterprise. We're not an NGO. We need to ensure that this tool also survive for a long term. So I think these types of things have been core to how we've built our tool so far.
Thank you so much, Kidis. And now over to you, Benjamin. Please tell us about Jacaranda Health and your journey.
Thank you for having me. And I'll start by correcting the number. We've served 3 million moms so far. We've served 3 million moms so far, not 1. Yes, not
3 million
1.8.
moms, okay.
Yes. So just to give a little bit of context of why Jacaranda does what it does. An average American woman will ask Google 1,000 questions during their pregnancy journey. But back at home in Kenya, our moms don't even have access to phones. They don't even have access to the internet. So anytime they want information, the closest place they can get this information is their friends. And I don't know about you, but if I took advice from my friends all the time, I'll probably be in jail right now. But yeah, so from that, we thought, how could we empower these women through their pregnancy journey? And their newborns after they give birth. And just like Tiago, we didn't start with AI. We had a bunch of help desk clinicians sit, and we provided an SMS platform that moms could just ask us questions. And at that point, we were processing at least 100 questions a day. That's easy to handle, right? Two people can handle that. But then two problems showed up. One, we had really benign questions being asked. And most of these came from culture and beliefs. Things like, can I eat eggs? Can I eat avocados during my pregnancy? And I don't think anyone wants to sit and answer 100 can I eat avocados question at work. It becomes boring. And the other thing was we could quickly see that those questions will easily move from 100 to 1,000 to 10,000 to 12,000, which we handle right now. We process 12,000 questions a day. And the question was, how do we serve the mom, one, faster? And how do we make it easy for our help desk agents? Because, again, we don't want to work with people who are bored at work because we are asking them if we can eat eggs during pregnancy. So that's where we started thinking about technology that we could use to at least help the help desk agents, the human help desk agents that were answering mom's questions. And at that point, our first hurdle came, which was moms in Kenya, and I think this has been mentioned a lot as something that happens here in India. There's no conversation that just has one language. When we are talking to each other in Kenya, we would mix mostly English and Swahili. And at that time, most LLMs were really good at English, but they knew nothing about Swahili. And the Swahili they knew was more like the university Swahili, which no one uses in their day-to-day conversations. So our first hurdle was to figure out how do we get a model that can understand Swahili that everyone speaks. And that's how we built, based on Llama 2, that's how we built Uliza Llama, which basically means ask Llama. We trained this model with data that was given to us at least by the government, and then for data that we had to hire people to translate, so manually, because at that time we also didn't have a lot of the tech for very good translation like we do right now. And then after that, from the previous questions that we had, where help desk agents were responding, we had at least 1,000 questions and answers. We used that as context for the things that we would expect our moms to ask. So that, in combination with policies and other documents from the Ministry of Health, the WHO, to give that model the context that it needs to respond to our moms. And that model we called Uliza Mama, which means ask a mom. So at that point, we had something that we thought worked, and we put it out to moms, and we quickly started learning that this is not what they wanted. Moms do not want, as much as you're giving them clinically accurate information, they do not want you just texting them without even saying hi. They do not want you telling them, a good example was given the other day, they do not want you telling them, you'll die, don't worry. No, they want you to be, to have some empathy when giving them this information. And we had to iterate and fine-tune the model for these specific things. And the other thing was we wanted to know if we are actually delivering value for these moms. And the only way to do so is to ask the moms themselves. I mean, you could do a bunch of studies around that, but if you're not talking to the actual user, then you're not necessarily getting the feedback that you need. And one of the things we added was making sure that after every response that we give the mom, we actually ask them if we're providing value to them. And that created a basis for what we want our model to do and how we want it to work. And over the years, we fine-tuned that to the point where now we're identifying risks in the questions that they're asking, and that's where we've still kept the human in the loop. Because we do not want a situation where a mom is portraying some risk in their pregnancy and still want a machine responding to them. So anytime we have danger signs, those are handled by still our human help desk, who would call them and direct them to, for referrals and how to seek further care. Yeah, so I think that's the journey of Jacaranda.
Benjamin, thank you so much.